We are living in an ever-changing, rapidly changing and interconnected world where social, economical, political, and technological changes are having enormous impacts on all aspects of life, including health and wealth. In less than 20 years, Shanghai has been transformed from a piece of farmland to one of the cosmopolitan cities in the world, with all its implications on the way how we live, how we eat, how we move, how we sleep, how we choose, and how we want and feel. In the last 3 decades, the GDP of China has gone up from 4,000 to 40,000 renminbi. This is accompanied by the increase of diabetes prevalence from less than 1% to 11% during the same period of time. Diabetes is more than a disease due to unhealthy eating or not enough exercise. It is an exemplary example of how rapid societal changes is transformed into a personal challenge requiring a societal solution. In emerging economies like China, rapid urbanization has created a weight-increasing environment promoting obesity with a lot of skyscrapers, automobiles, mechanization, bioactive pollutants, excessive use of alcohol, smoking, and also energy-dense processed food. In some communities, these rapid changes in lifestyle has disrupted traditional way of living and also created social disparity, which actually puts many of those disadvantaged and also genetically susceptible, very vulnerable, as they struggle to lead a new way of life in this rather unfamiliar world. Life is all about energy. And when you talk about energy, then we are talking about effective management of blood glucose, which should be kept between 4 and 8 millimoles per liter at all times in order for effective energy storage and utilization. This is the pancreas, which weighs only 60 grams, which is the size of a golf ball, lying silently behind the stomach. Within this tiny organ, 90% of the cells secrete digestive juice, and only 5 grams, which is less than a teaspoon of sugar, form the islet that will secrete insulin on a minute-to-minute basis to maintain that glucose within that very narrow range. Thus, abnormal architecture of this pancreas islets and also abnormal regulatory mechanisms will actually make a person's blood glucose fluctuate with whatever he does, whatever he eats, and whatever he thinks. And these fluctuations of blood glucose level would destroy all blood vessels and also nerves in a silent but sure manner to destroy all organs, including but not limited to heart disease, stroke, kidney failure, cancer, dementia, and premature mortality. Globally, 1 in 11 adults have diabetes, and the majority of them are actually not diagnosed. 1 in 7 pregnancies are affected by gestational diabetes, and 500,000 of children had type 1 diabetes, and without insulin, they would die. Currently, we spend 1 in 12 healthcare dollars are spent on diabetes. And the majority of this is on complications, which are preventable in the first place. By the year 2040, there will be 600 million people with diabetes, which is the size of half of the population of China. And the majority of these will come from low to middle income countries who have the least capacity to deal with this human disaster, which is killing 1 person every 6 seconds. Yet, diabetes is highly preventable and also treatable. A story of twin sisters that I personally know, explaining it all. Both of these twin sisters were diagnosed to have gestational diabetes at the age of 30, and both of them developed diabetes at the age of 35, and both of them refused treatment in the first few years. But the one living in Hong Kong was finally persuaded by the relatives to seek management in a multidisciplinary diabetes center, where she learned about the what, why, and how of diabetes, and adopt a new way of life. At the age of 50, she's well and alive, treated with multiple medications, including insulin. And she's expected to live to the age of 80 or beyond, with the support from her friends and relatives and care team. But sadly, her sister recently died at the age of 50 with kidney failure and stroke because of poor adherence, fragmented care, and less social support during these 15 years of illness. Thus, diabetes is highly preventable and treatable, and indeed, over the last 3 decades, we have learned a lot about the causes and consequences and treatment of diabetes. In the early 70s, researchers in China have already reported that using structured lifestyle modification to improve physical activity and also healthy eating, we can reduce the risk of diabetes by 40% and delay the onset by 10 years in middle-aged men with pre-diabetes. 23 years later, this was translated to 20 to 40% reduction in cardiovascular disease and also death. In the early 80s, researchers from Hong Kong have reported the exceeding low death rate in 80 subjects with type 2 diabetes and hypertension, participating in the clinical trials, receiving structured care by a stable doctor-nurse team with good management of risk factors, with only 3 deaths in 7 years. This is in contrast to 24 deaths in 80 patients with the same clinical profile being managed in the same hospital, but in a busy clinic where care is more random and fragmented, indicated that team-based structured care can make a big difference to these high-risk individuals. Thus, prevention and good care can make a difference, save life and save money. But the reality is the majority of people with diabetes and prediabetes are not diagnosed, treated, and controlled. So the challenge is to devise an innovative solution where we can identify these individuals early for proactive management by the right team at the right time and the right setting. And I think this is really where genomic medicine may offer an avenue to enable identification of these high-risk individuals and distinguish them from their peers with similar clinical profile in order to start an engaging and personalized conversation to motivate behavioral changes and to start treatment if early, if necessary. In China, a 40-year-old middle-aged man who smokes, got a family history, and also a bit of overweight, his lifetime risk of diabetes may be 1 in 4. But depending on his genetic makeup and the interactions between the modifiable and the unmodifiable risk factors, the modifiable being mainly smoking and obesity, his lifetime risk of diabetes may range anywhere from 10% to 60%. Indeed, prediction, prevention, personalization, and participation is what we're really yearning for. Each person with diabetes has a unique set of profile, with 1,000 patients having 1,000 stories and 1,000 outcomes. By having a good registry, we can track these critical factors over time to unravel the complex interactions of these risk factors on clinical outcomes in order to stratify risk and triage care. At the same time, if we can empower the care providers and the patients with these risk profiles and actionable items such as blood pressure, glucose, body weight, and lipid, we'll be able to reduce clinical inertia and also poor adherence. In this joint Asia Diabetes Evaluation Program, which is a web-based tool with built-in protocols, a validated risk engine, a personalized reporting, and also decision support, we were able to change the workflow together with the team and augmented by information technology to visualize risk and to motivate behavioral change and to individualize care to make a difference to these patients' outcome. So in this era of fourth industrial revolution, innovations such as artificial organ, artificial intelligence, precision medicine, stem cells, wearable devices, robotics, and so on, give great promise to improve life, to protect health and prevent diseases. We must not forget that we must use multi-sectorial partnerships to create a sustainable and also a health-enabling ecosystem, a caring and also a just society, and an affordable and integrated healthcare to bring out the best of these technologies to preserve humanity. It is here where the government must take the leadership role to use mandates and fiscal measures to protect the environment, to make sure that the citizens have exposure to safe water, safe air, and safe food, and build healthy city to promote healthy exercise and also healthy eating. Like food and shelter and clothes, health is a basic human right, and these people should have access to basic care, essential medications, general and also health education. While the government will continue to nurture the environment to promote interdisciplinary innovations through partnerships of innovators, knowledge workers, industry, and foundations, they must also protect the disabled, the disadvantaged, and also some of those disillusioned. It is only by embracing this diversity, creativity, and humanity will we really realize the vision of using interdisciplinary innovations for the holistic development of mankind. Thank you.
The opportunity to address non-communicable diseases is greater in China than anywhere else in the world. To design the solutions that are appropriate for a population of 1.3 billion people, we have to understand the boundary conditions that define the types of solutions that will function within and around those boundaries. The scope of the problem of non-communicable diseases in China is tremendous. 900 million is the number of people in China who smoke or are exposed to secondhand smoke on a daily basis. I live in Shanghai. There are 14 hospitals there that see more than 5,000 patients a day. The healthcare demands of China are enormous. China recognizes the problems that it faces, but demand exceeds supply. A few weeks ago, I interviewed a pediatric hematologist. She sees 70 patients in a 4-hour clinic in the morning. That's 3.5 minutes or less for a child with childhood leukemia. The frustration for both physicians and patients, nurses, everyone in the system is enormous. Part of the problem, though, in China, the data from 2015 suggest that in 2017, the healthcare system in China will process 8 billion visits. The PRC is trying to address the problem. It recognizes the problem. The Chinese healthcare system is a victim of its demographics. 131 million people have moved into an older category. There's about 114 million diabetics, and migration has moved about 270 million people into the cities. Additionally, China has done things to address its health problems that also potentially have increased demand. In 2008 and 2009, it instituted largely universal health coverage, further increasing the surges in demand. China is trying to address the problem. Since 2010, China has doubled its spending, per capita spending. And in cities like Shanghai and Beijing, it's doubled its spending again. Nevertheless, the amount of dollars that exist in healthcare constitute one of the constraining conditions in which solutions need to be created. Similarly, China doesn't have enough physicians. The number of physicians in China per 1,000 patients are about 50% less than most of its economic neighbors. The 12th five-year plan included significantly increasing the number of physicians, and it included increasing their training. But it's going to take at least a decade to bring those resources up to demand. China has also recognized that physician training in China has not been adequate. Demand has surged, but the system is still a legacy system in some ways. 44% of Chinese physicians don't have a bachelor's degree, and only 12% have a graduate degree. China is changing this. It's mandating higher levels of education. But again, if you've got 2.5 million physicians in a country, it's going to take 10, maybe 15 years to address this knowledge gap. So there's a capacity gap, there's a financial gap, there's a knowledge gap, all of those. As Juliana said, physicians don't have enough time. They don't have enough time to develop a care plan. They don't have enough time to manage patients longitudinally. They don't have enough time to educate. They want to do these things. And they don't have time to make a proper diagnosis, which is a cognitive skill. So 53% of diabetics in China, at least, are undiagnosed. Cancer is the #2 killer, #2 chronic disease, and cervical cancer is probably the most preventable and curable of cancers. But in China, cervical cancer needs attention. Currently, only 1 woman in 5 gets a pap smear. Part of it's public education. The other part of it is there simply are not enough pathology and cytology resources to do pap smears given the demand. Breast cancer, huge problem in China. Interestingly, breast cancer in China occurs 10 years earlier than in the West. Breast cancer is increasing, and when it's diagnosed, in part because of the way the health system is and because of lack of awareness, when breast cancer is diagnosed in China, it's typically 1 or 2 stages more advanced than it would be in the West. And as a result, the type of care that's provided is interventional. Too much of healthcare in China is episodic and interventional. If you look at a curve, and on one extreme is a radical mastectomy, and the other end of the extreme would be health outcomes that are superb because they're achieved through public education, through behavior change and prevention. Most of non-communicable disease care, as Juliana suggested, exists on the intervention limb of this. What needs to happen here, really and everywhere, is to move up this curve. The next step in the evolution of trying to manage patients with disease risk is screening. And it may be pap smears, it may be mammography, it may be low-dose CT for lung cancer screening. This starts to move the management of disease up a curve so better outcomes can be achieved. What's really interesting and potentially relevant in China are unique ways that are coming online of diagnosing. We're in conversations with the Silicon Valley company that does deep learning diagnosis for lung cancer. They've pretty conclusively demonstrated that their ability to diagnose lung cancer in a chest X-ray is 10,000 times faster than a human radiologist, and inter-observer variability is essentially zero. They're introducing technology with AI to diagnose lung cancer that's not otherwise visible on CT. These things move healthcare management from intervention to screening to identifying almost the precursors of disease. And I would probably put the future of liquid biopsies in here as well. All of these things are moving the care model from intervention up to prevention before disease is established. However, these things are expensive. They're especially expensive in a country this size. Demand for healthcare always exceeds supply. When we have to figure out ways that we're going to address the overwhelming demand. So a paper was published a couple of years ago that said about 120 million women in Shanghai or in China need a mammogram. For China to do one mammogram on every woman that needs it, the line would be 40 years long. That's the magnitude of the demand. So we have to figure out how we're going to allocate scarce resources, whether they're laboratory or diagnostic, to a population of this size. This is a risk curve, theoretical risk curve for breast cancer. 120 million women. Number of patients would be on the vertical axis and risk is on the horizontal. Most patients have low or intermediate risk for breast cancer, and certain segments are at high risk. A curve like this for a population really represents an amalgam of dozens or hundreds of individual risk profiles. Currently, as best as can be determined with the databases that exist, 13% of cancer patients are in registries. To tackle these sorts of problems and decide how to allocate resources, to decide who goes to the front of a 40-year-long line, to decide who needs a $2 drug versus a 2-cent drug, what we need to do is develop very large databases in this country on which analytic engines can start to do risk prediction. China is the place to do this work. China has the population. China has the disease burden. China has the computing power. China has, in some ways, uniquely, the political continuity to tackle problems of this type. So I would invite anyone in the WEF or anywhere in healthcare who wants to address non-communicable disease to direct their attentions to China. Thank you.